Now, moving on to our first section, that is the proximal humerus fracture. As you know, humerus is a bone which is connected to the body in with the glenohumeral joint to the scapula, and then it constitutes as the first bone of the upper limb, and eventually on distally it's connected to the radius and ulna forms the elbow joint. In this section, we'll be briefly going through the clinical features of the proximal humerus fractures, what is the imaging and what are the treatment options, and how do we classify the proximal humerus fractures in case of the children. So what a fracture of the proximal humerus, the most common mechanism of injury is actually the follows the fall on the outstretched hand. Fall on the outstretched hand is a very pathognomic abnormality, especially in case with upper limb fractures. Fall on the outstretched hand can result in a Cooley's fracture of the distal radius, can result in a distal radius, elbow fracture dislocations, could be supracondylar fracture, distal humerus, or even the mid shaft or the proximal humerus fracture as well. And fall on outstretched can also lead to clavicle fractures. So usually when our upper limb is not made for the load, but when the load actually gets transmitted over the upper limb, this usually results in the fracture of one of the bones of the upper limb. Other common cause is the shoulder dislocation. Shoulder dislocation, it could be traumatic, especially the anterior, but it could also be associated with convulsions and electrocution injury, especially the posterior dislocation. And in this kind of a high energy trauma in which there is either anterior or posterior dislocation, there is always a chance that proximal humerus fracture dislocation may also occur. Then sometimes what happens is the trauma is such a high energy that it's not only fracture, there's also fracture dislocation. That is, the humerus is broken, and then also the joint is actually disturbed as well. The classification in the children is slightly different as it is based on Salter-Harris classification, but in case of adult, the classification is based on the structure of the humerus. If you see this is the proximal humerus. It has 4 parts actually. Greater tuberosity is the one part, lesser tuberosity is another part. This shaft or metaphyseal area is third part, and articular surface is actually the fourth part. This is how the classification is divided into parts, whether 1 part, 2 part, 3 part, or 4 part fracture. Usually 1 part means there is no 1 part fracture, because if there will be a fracture, this would split this into 2 parts. So it's 2, 3, or 4 part fracture. But this is how the parts are actually taken. Greater tuberosity is one part, lesser tuberosity is another, articular surface and shaft as one part. Now coming to the clinical features, what would the patient present with when there will be fracture proximal humerus? There will be fracture which often will be firmly impacted. Patient may have pain, may not be very severe, but there may be sometimes children actually usually come with severe injury. Bruise on the upper part of the arm may be present as well. Sometimes there is decreased range of motion, or there is absolutely patient is unable to move his or her arm. We have to look for the axillary nerve as well as the brachial plexus injury, because sometimes this may be associated with neurovascular bundle as well, especially when the fracture proximal humerus involves a high energy trauma. We must look out for associated injuries to the chest along with the clavicle, scapula, as well as the distal humerus fracture. Sometimes there may be associated floating shoulder, or there may be associated chest injuries as pneumothorax, hemothorax as well, or multiple rib fractures as well. Now this diagram underlying briefly describes the classification of the proximal humerus fractures in children. The mainly classification is followed is actually the Salter-Harris type. Type 1 is the common, especially in the children less than 12 years of age, and actually the fracture line passes through the physis or through the substance of the physis. Type 2 is when there is the metaphyseal line going from physis then into the metaphyseal region. Type 3 is when it's involving articular site in the epiphysis. Or type 4 is also called when it is involving the physis, epiphysis, as well as the metaphysis. So this is how mainly it's divided in, and that's the Salter-Harris classification, which is generalized classification for other bone fractures as well. Now coming, if a patient, a child or an adult comes to you with a history of trauma towards the shoulder, and you're suspecting there's decreased range of motion, there's pain and tenderness, and maybe a crepitus of the greater or lesser tuberosity as well, then what are the imaging which is required? X-rays include, if you see, the first and foremost is an APV of the shoulder. This is an X-ray which is showing area of the metaphyseal shaft accumulated fracture, but there is also associated greater tuberosity fracture as well. Lesser tuberosity seems to be intact, but although displaced, and article surface seems to be intact. So this is a classically two-part fracture which is involving the greater tuberosity and the shaft of the humerus. Sometimes there will be undisplaced fragments which may be seen, but sometimes there is a highly comminuted and displacement fragments may be seen as well. In younger patients, fragments are more clearly separated and they're very clearly visible as well. And sometimes AP view is not just enough. We have to see whether this is associated with dislocation or not, or there is associated subluxation or not as well, because there could be high energy trauma, there could be fracture dislocation of the shoulder. In that case, we need axillary and scapular lateral views or scapular Y views. We may need 3D CT scan as well with reconstruction, because when we are dealing with highly comminuted fracture, especially the 4-part comminuted fracture, sometimes we do need 3D CT with the reconstruction, because we need to review what are the different fragments which are there and how we can fix them. So after healing, sometimes humeral head gets subluxated inferiorly, so the X-rays and CTs may be required even after the treatment as well. Now coming to the treatment. Generalized treatment in case of it's a minimally displaced fracture, that is if it is less than 5 mm of displacement in case of greater tuberosity, less than 1 centimeter of displacement in case of shaft and lesser tuberosity, and less than 45 degree of angulation, then this is the criteria in which if it exceeds this criteria, then we have to go for operative fixation. Otherwise, usually the conservative measures are enough. The most common is the arm in the sling. As you can see, usually a polysling is given and rest is given for 4 to 6 weeks, and then the gradual range of motion or rehabilitation is started. Then we have to start the gentle shoulder passive movements initially in the first 2 weeks, and eventually moving on to active exercise. And active exercise and strengthening exercise is usually left after 6 weeks when the bone is completely united. Now coming to the fractures of the proximal humerus in children. The classification is again very similar. That is the Salter-Harris classification, which has 5 types, but usually the first 4 and 2 are more common in children, especially in the case of fracture proximal humerus. Diagnosis sometimes difficult, but the best option in children is, if you're not sure about the diagnosis, just get an X-ray of the opposite limb. Probably, especially in case of physeal injury, it's very easy to understand whether there is a pathology on this side or not as well. Consideration, usually we have to give a consideration to clavicle fracture and brachial plexus injury, because neurovascular compromise are when there is a clavicle as well as scapular fracture. This makes it a floating shoulder, and these are kind of an indication in which we have to go for some kind of a surgery. So the important point is actually why it is important, because sometimes what happens is the metaphyseal region of the humerus is could be simply a unicameral bone cyst as well, which usually once patient may have a trivial trauma resulting in a fracture, and the child now presents with a fracture, but actually there was a cyst over there which has actually resulted in a bone fragility and a fracture. So in children, especially they come with a proximal humeral fracture, we have to rule out, especially in the case of metaphyseal region, whether there was some kind of cyst present over there or not. And then there could be some kind of a benign tumors as well, which may be seen in the children. We have to rule them out as well. Simple cyst, which is usually the unicameral cyst, usually unites, and all you have to do is to give coaptation splints or sling for a few weeks, and eventually the bone unites as well. In this section, we have briefly discussed what are the proximal humerus fractures in adults and in children. The most common mechanism of injury is usually the fall on the outside hand, may be associated with fractures and fracture dislocation as well. In children, the most commonly classification is Salter-Harris classification, and in adults mainly it's usually considered as 2-part, 3-part, or 4-part fracture. The treatment as often is depending upon what kind of injury it is. If in case of greater tuberosity is displaced less than 5 mm, and if there is less than 55 degree of angulation of lesser tuberosity or the fractured fragment, usually the treatment is conservative in form of a polysling or a sling for 3 to 4 weeks. Initially for 2 weeks, the arm is immobilized, then gradually passive range of motion is started. Once after 4 to 6 weeks, when the fracture is united, we can start active range of motion so that and then the shoulder strengthening exercises can be restarted as well. Thank you very much. Keep watching sqadia.com.